Okay, so my name is Tione Buranda. I'm going to talk about our assay that measures the activity of white blood cells. Those are the cells that usually conduct surveillance throughout your body so that if there's a presence of an infectious particle like a bacteria, then they'll be able to detect it. And so the idea behind our assay is to be able to measure the activity of your white blood cells to see whether or not there's a presence of bacteria. In this case, if somebody shows up at the hospital and the clinician suspects that the patient might have bacteria infection, and then they would test them. Just before I start, I just want to point out that we just recently, I signed up in September, no, November, I signed up for office hours with New Mexico Startup Factory. And so actually we just submitted an STTR grant for this assay for January 5th. So there is something to signing up for office hours. So I don't, okay. All right. So what is sepsis? Basically, sepsis is usually when you get a bacterial infection. Normally, not all bacterial infections lead to sepsis, but some of them, usually your body reacts very violently to the presence of the bacteria. And so it becomes a syndrome where you become very, very ill because of the presence of the bacteria inside your body. And so if you present at the hospital and they suspect that you have a bacterial infection, the first thing that they're going to do is they're going to take some blood sample for blood culture, but at the same time, they're going to give you antibiotics. And this they do in case that you actually have, it's true that you're infected, and so they would like to minimize the damage that the presence of the bacteria might cause to you. But at the same time, administration of antibiotics are also going to compromise the ability of the culture assay to come back and tell the physician what sort of infection that you have. And so the gold standard is trying to grow uh, bacterial cell culture to see whether or not you can, and usually this takes about 5 days to come back. And so usually that's a very long time for you to be waiting to confirm whether or not a person is septic. And so the idea behind our assay is to cut that time short, be able to tell whether or not there is some evidence of infection in your body. So this is a scenario that happens. You can either be in the hospital, you acquire the infection, or you can acquire the infection before you are admitted to the hospital. And so this is the case when you actually are admitted to the hospital. And our view is that, okay, you can draw the sample. And so in your body, this is your blood circulation. If there's presence of bacteria, your white blood cells are going to recognize the presence of the bacteria and they're going to become activated. They might also multiply in size. Normally, the clinician, the lab will actually tell whether or not your white blood cells numbers have increased. But at the same time, sometimes for patients with sepsis, the numbers might go up, but then your immune becomes compromised so that even though you have high number of white blood cells, they might be totally paralyzed, they're not activated. And so that does not tell them whether or not is your immune system still responding or is it just large number of white blood cells that are not doing anything. And so our assay actually has the ability to be used in conjunction with the blood test that's normally a standard of care in a hospital to tell you whether or not, okay, is this person really infected and are their white blood cell system activated or are they inactive because they are now immunocompromised. So just to look at the granular uh, picture, what's going on, you have your physiological response to infection, you present at the hospital, they draw your blood, they complete blood count with a differential weight. This way they know you have so many neutrophils that usually measure the extent of how your innate immune system is responding. And then you peripheral blood cells like lymphocytes that tells you whether or not your adaptive immune system is really active. And this is where the G-trap assay comes in. We can measure the activity of your small GTPases that are expressed inside your white blood cells. So if RAC1 usually is the engine that drives your white blood cells to migrate to sites of inflammation. And so this is just some experiments that we did. That here are people who came to the hospital. They were tested for a few days and the blood test came back culture positive. And this is somebody whose immune system was activated. And this is a control sample where we looked at about over 100 patients and see, okay, if your immune system is at rest, then it's gonna be, this is the level of activity. But if you're infected and inflamed and your immune system is working, this is the kind of level of activity you're gonna see. But if somebody comes in, they are declared to be positive for infection and they're immunocompromised, you're going to see that the activity is very low. It's even lower than some of the normal activity. So you know that, okay, this person is infected, their immune system is not working, so they're in danger of just developing a worse medical condition because the immune system is not fighting off the bacteria. And so this is the kind of information that you would get on day one when the patient presents at the hospital. So this is a busy figure, but it just says, okay, we have collected a lot of data on this. And what this, the left-hand side, this side shows you the people who are highly inflamed, normal immune response. And on this side, people who are immunocompromised. The top figures are just, it's kind of busy, so I'm just gonna leave that alone because it's on log scale. But what really the take home message is that here we're looking at individual patients, that we're looking at longitudinal samples where this person comes in, you take your first day blood sample, they are given antibiotics, but they are not responsive to antibiotics because their immune system remains activated. So if you give this person some antibiotics and they're not responding, you know that the antibiotics are not working. And so you could actually give them a different set of antibiotics. But also this person here, day 0, they're active, they're given antibiotics and they're actually responding. And so it also tells you that when it comes down to baseline, okay, so the other thing I forgot is that this here is the 110 controls. So you can see that all these people are really activated above the controls and that this person is responding and all these other people are not responding as well as they should. But what this tells you is that A, you give antibiotics, the person responding, you know when to stop, so that you can actually not to overprescribe antibiotics. Whereas these people, you know that, okay, this person, I gave them antibiotics, their immune system is not responding, so the antibiotics are not working because right now we don't know what kind of bacteria they have. We can change the antibiotics to some other medication to see whether or not this will drop. And so this is, would function very nicely as a clinical decision tool. Now let's look at the people who are immunocompromised. Okay, these are the controls. The scale is kind of compressed, so you can actually see that these are the controls, the 110 controls. And some of these people, they come in, they are totally, their immune response is not even there. And so it tells the physician that, okay, there is a problem with this person. And it sort of guides their clinical decision as to how they can treat this person who's immunocompromised and they're not responding to any type of medication. And so the other aspect of this assay is that somebody might come into the hospital, it's a trauma patient, and they acquire an infection, say a week after they're hospitalized. And so on the left-hand side, he's just looking at the vital signs of the person, and there are no significant changes that can tell you that, oh, there's something going on with this patient, we need to do something. Whereas when we look at the results of our G-trap assay, you see this person came in on day 1, they suspected that they might have had some infection, and they put them on broad spectrum antibiotics. And so you can see that there's some, the data is kind of noisy. The antibiotics are keeping the patient under control. And then on day 5, the culture came back positive. And so they narrowed the antibiotic treatment. And so these antibiotics were much more targeted and they're working. And the doctors decided that after day 3 that, okay, the person is doing okay, so we're going to take him off antibiotics. And what happened, the bacteria came back really strong, and their response just started going worse and worse. And then they had to put them back on antibiotics on day 14. Whereas if they were monitoring this person, they would have known that the treatment had not worked as well as they had imagined. And so this would have been a nice clinical decision tool. So I think, oh, okay, I guess that's the end of my talk.
Great, thank you, Tione. Is there any questions? I'll pause for a second to see if any come in. So I do have a question. So kind of one of the biggest things when developing a new assay or a new treatment is getting reimbursed by insurance companies.
Yes.
So could you tell me what the biggest selling point to the insurance companies for reimbursing, like how would this benefit insurance company where they would want to, reimburse this test?
Okay, so in order for the test to be accepted, you have to go through, to validate through a clear lab like TriCore. That's what we're working through. And then once it's pre-approved, it's approved for use in a clinical lab, then it has to, you have to be awarded a code, a medical code number, so that it has to be accepted into database like CMS, so that the billing that is actually a code associated with the assay. And so if Medicaid accepts the assay, then that's how you would get into, the insurance company would actually reimburse you for it. But I think the point is that if you can tell that somebody has an infection earlier before it develops into full-blown sepsis, then I think that would be very beneficial in terms of saving money, but also in terms of the issue of antibiotic stewardship is a very big thing in terms of CMS as well as NIH, because if people keep prescribing antibiotics, we're going to come to a stage where we just don't have the bacteria are going to be so resistant to the existing antibiotics that it's not going to be possible to be treating people. So I think the notion of being able to tell whether or not the person is responding to antibiotics and when to stop, I think that's a very important selling point, because normally people just, when we did our I-Core customer discovery was that, okay, physicians normally when they prescribe antibiotics, they usually, it's kind of like football scores where it's either 3 days or 7 days, 10 days, but there's no rationale for that. And so.
Okay, thanks. We have one other question I'll ask before we move on. So if I Google rapid sepsis tests, I get about 20 million hits. Can you succinctly state your advantage over other rapid tests?
Yeah, so our advantage is that it's more of it's a clinical decision tool where you are getting results on the same day that the patient is coming in. And also it works well with the complete blood count test that, that's the bread and butter of every physician, that you come in, they take your blood, they count your white blood cells to see whether or not you're elevated or low. But for our assay, it also tells the physician that the patient is presenting a normal immune response or they're immunocompromised. And also that because everybody, the doctors are encouraged to prescribe broad spectrum antibiotics, the doctor can tell whether or not today I prescribe the antibiotics, tomorrow is the patient responding or is the patient not responding, without having to wait for a result telling them that the patient is infected, which is normally 30% of the time, otherwise 70% of the time, it doesn't work. And also, normally people, when they come to say UNM hospital, they probably were given antibiotics at some other clinical setting. Like if you were in a nursing home, you probably were prescribed antibiotics and you're not going to be able to get a positive culture. But I think if the physician is able to tell whether or not your immune response is normal or you're totally immunocompromised, I think that's a very big thing to.
Okay, great. Thank you.
And I think once we actually publish that sort of data, I think that will be, it'll be just the market that, people recognize how important this tool is.